All right, everyone. Thank you so much for joining us at 8 a.m. after the 30th anniversary party. This is truly a dream for me to be able to be on this platform with this amazing cohort of individuals. Pop out around here. This amazing cohort of individuals who have agreed to talk about climate change and emergency medicine. So I'm Renee Salas. I'm the lead author of the Lancet Countdown Brief for 2018 for the U.S., and I'm a physician investigator at the Harvard Global Health Institute and work clinically at Massachusetts General Hospital and Harvard Medical School.
And I'm Jeremy Hess. I'm an associate professor of emergency medicine, environmental occupational health sciences, and global health at the University of Washington. I'm also the director of the Center for Health and the Global Environment there. It's a real pleasure to be here with you this morning and an honor to be here with our panelists. Dr. Blomkalns is the chair of emergency medicine at Stanford. Dr. Heilpern is the CO at New York Presbyterian Weill Cornell Medical Center. Dr. McCarthy, unfortunately, can't join us today, but the CO at Memorial Hermann Health System in Texas, and Dr. Jeremiah Schuur, the chair at Brown. Thank you. We are here this morning because climate change is impacting the work that we do, and it's impacting our patients. And importantly, there are now several stories we can tell about particular events and climate change's contribution to them, but more importantly, how they affected the health systems that they impacted, and what those health systems did do, could have done to prepare and respond, and how we can learn from their experience to anticipate future events and better prepare for ours. We're here particularly to tell you about two things. The first is the Lancet Countdown on Climate Change and Health. And this is a global report issued every year that covers global activity related to climate change and health. And there's a substantial physician presence in the Lancet Countdown, and particularly an emergency medicine presence. And we felt that was important to bring to the community, and particularly to highlight the U.S. country brief of the Lancet Countdown, which outlines the activities relevant to the United States, which Renee is the lead author on and I'm the senior author on. And we're going to go over some of that with you. Our second goal is to present the senior leadership EM perspective on this issue, to highlight these questions and think through issues related to preparedness and mitigation and how the Lancet Countdown and other relevant publications influences practice going forward. So I'm going to tell you a little bit about the Lancet Countdown and then hand it over to Renee, and she'll tell you about the brief, and then we'll move on to our panel and hopefully a lively discussion. The Lancet Countdown is published every year in the fall in the Lancet. It is a global report. It covers 5 action areas. The first relates to or is an assessment of climate change impacts globally on health over the last several years. And there are well over 40 indicators that are tracked every year. The report each year picks several and dives deeply into them while reporting on all of them. The second area is related to adaptation planning. So adaptation is preparedness in response to climate change and related things, extreme weather events and other activities, population migration, et cetera. And the second group covers adaptation and preparedness in the health system the world over. The third relates to mitigation. So the health sector has a substantial carbon footprint, and there's clear evidence that with attention to this, we can reduce our carbon footprint and do it quickly without impacting patient care. In fact, we can often improve patient care and reduce costs while doing so. And so there is an accounting of global mitigation activities in the health sector that's updated every year. Then we look at finance and economics, funding flowing into adaptation and mitigation activities in the health sector, country by country. And lastly, we look at public and political engagement of the issues. And one of the take-homes from the report in 2018, and it's of course going to be a persistent theme, is that climate change in many areas has the potential to overwhelm health services. Of course, this is central to what we do. We are frontline for maintaining resilience to disasters and emergencies, and it should concern us when there's potential for something like climate change to overwhelm our capacity. We saw this in Beira in Mozambique this year, where it was hit by a really powerful tropical cyclone, made significantly more powerful by climate change. And then another storm, several weeks later, had massive impact on the population's health and on the health infrastructure of that region. The Lancet Countdown is a global report to highlight and emphasize activities in specific countries that are particularly pivotal and where population health is a real issue. There are country briefs that are written by teams of Lancet Countdown authors and others and engage with local, national infrastructure, leadership organizations to articulate the issues and frame them in a way that's particularly relevant and engaging for audiences in each of those places. Here's a list of the different countries that are issuing country reports, and as I mentioned, Renee is the lead on the one here in the United States. We, as with the Global Lancet Countdown, we have a large number of partners that participate each year with us on developing the Lancet Countdown, preparing the material, reviewing it, and working to get the word out about activities and highlighting the key findings from our report. As I mentioned, Renee is the lead author, indefatigable, an outstanding colleague. I'm the senior and get to take credit where credit isn't due. And then Paige Knappenberger is also an author and the visionary behind the communication strategy for the report. Here are our partners last year. The list is growing. It's extensive. And we've really formed a nice coalition around climate change and health with a wide range of academic and other institutions here in the U.S. With the release last year, we got extensive coverage. We're hoping this year to have even more. This is a hallmark of the Lancet Countdown process. It's garnering quite a bit of attention, and this has to do largely with the fact that physicians are a trusted source of information on this topic. We're seen as non-biased and evidence-based, and our passion around these issues is important. With that, I'm going to hand it over to Renee to tell us more about the U.S. country brief.
Thank you so much, Jeremy. And Jeremy is far too kind. His senior leadership and mentorship has been key in this process. So I'm just going to try to go over and highlight some of the key aspects of the brief, but I really want to focus, obviously, a lot of our time on our discussion with our esteemed panelists. So we really had 4 messages that came out of the brief. The first one being is that climate change was threatening the health of Americans now. Thought it was incredibly important to continue to make those connections between climate and health for the lay public, and especially for those with power to influence policy. And then we lay out kind of a variety of resources in addition to recommendations for implementing the solutions. So here, as we say, the first one is we really thought there needed to be improved preparation on both the federal and state level, in addition to increasing robust research funding capacity around these health impacts. The health impacts are enormously broad, as you see here, and I can make an argument that all of these exposure pathways will bring patients to our emergency departments. In addition, as I think we've all experienced, you can't really scroll through the news without seeing the increasing rise of extreme weather events, some of which our panelists have experienced firsthand. And so there's an increasing rise in billion-dollar weather and climate disasters, which was highlighted. In addition, while particulate matter across the United States has been improving, it's actually been worsening in the western half of the country, secondary to wildfire smoke exposure. And vector-borne diseases have actually tripled between 2004 and 2016. Now, message 2 is that really making that connection between health and energy sources. So we need to make a turn to renewable energy sources and decrease our reliance on fossil fuels. And I would advocate that health needs to take a stand in that and make those connections, that there's a clear connection to improving health and saving lives. So despite what the general thoughts may be around the U.S. and federal thoughts around climate change, the carbon intensity of the energy system has been decreasing and renewables has been increasing. So we are heading in the right direction, but we need to have accelerated action at a profound pace. In addition, divesting from fossil fuels can be a way to take a stand around the ethical issues of fossil fuels, and it's something that healthcare organizations have begun to divest, acknowledging that it's just like divesting from tobacco. Lastly, for our third message, that's really highlighting adaptation, and adaptation is one of the other key aspects that we need to protect health for those that are most vulnerable. We really, though, have to increase our funding substantially within the health sector to increase resilience for hospitals and to protect vulnerable patients. And so we highlighted some of the local public health departments around the U.S. who have really been working to protect their communities and develop adaptation strategies. However, data that was from the global Lancet countdown for the U.S. specifically showed that only 5% of all of the U.S. climate change adaptation across all sectors was actually directed towards the healthcare sector. And that is a profound disservice and substantially needs to increase. And then lastly is the fact that we as healthcare providers are trusted messengers to deliver this connection between climate change and health. And so we need to ensure that we are educating our trainees, educating our practicing physicians, and then really truly unify the health sector voice. And so we presented some data that showed to what degree these different sources of information on climate change and health were trusted. And if you look to the far left, you'll see that a primary care doctor ranked highest. And so the lay public relies on us as healthcare providers, and especially as physicians, to deliver this message to them. So with that, I just want to highlight and kind of set the tone as we turn to our moderated panel discussion. And that's that the Lancet Countdown calls climate change the greatest threat, but also the greatest opportunity. The New England Journal of Medicine just said that climate change was a health emergency. Now, we have all been in a resuscitation bay where there has been a crashing patient, and we've had a very defined time point, right, to deliver the interventions that are necessary to save that patient's life. Well, the IPCC, which is a world federation around climate change, they have outlined that we truly have, and they have outlined this, by 2030, we need to dramatically decrease our reliance on fossil fuels and decrease greenhouse gas emissions. And so we have this profound opportunity, but also I think responsibility of being alive at a time point in history where what we do now, the decisions we make, the actions we proceed with, and the inaction that we are complacent with, that's truly going to determine the health of nations to come. So with that, I'm going to turn it over to Jeremy to kick off our panel discussion.
Great. Thank you, Renee. So we're going to ask our panelists a few questions and then open up the floor to discussion so that you can pose questions to them as well. And I have the honor of asking the first, and I want to ask a general question of each of you about how climate change may have already impacted your patients and your systems, how you're thinking about climate change going forward, and as leaders in emergency medicine, but also in your health systems, how you present and navigate this issue based on the experiences you've had thus far. Whoever would like to take the first crack, please. Thank you.
I'll start. I'm relatively new to the state of California, and born and raised in New Orleans, so hurricanes obviously are something I grew up with, is something that just happened every year essentially. But then moving to California, I'd been there about a little over a month, and I walked outside to walk my dog, and I thought it was a little cool in the air, and I thought, well, how charming, somebody has their fireplace on. And what actually I hadn't realized in that very moment that my entire world had just turned into a fireplace, and it was very interesting and very scary. So initially, We didn't see very many patients related to this. And this is, I'm referring to the wildfires in the fall of 2018. But actually, slowly, over the course of a few days, obviously respiratory complaints came in. But then there was a superseded kind of worry where people were worried that their chronic health conditions were being affected. When I'm not sure if that necessarily was true, but it's kind of the one actual situation where people's respiratory system was actually being compromised. But then the second thing where they were concerned about cardiovascular system and all their other issues that were going on too. So we saw a significant precipitous spike in asthma, COPD, but also our overall volume in the hospital increased significantly. So both inpatient and in the emergency department for what might seem like unrelated issues, but very well may be related. The hospital's response to that was, or at least in the acute phase was, and I thought it was actually pretty remarkable how they were able to put a high-grade HEPA filter at every door and every exit, which I don't know where they keep these things, but they came out in hundreds. And then it got to the point where people essentially were walking outside in masks. And it was sort of like this weird fog kind of look, and it lasted for close to a month. I mean, well after the fires were already gone. So I think Stanford and that area has been through this before, and obviously they're prepared for it, but I'm not sure we're ever really prepared for whenever the next fire is, because we certainly know that's just down the road.
So I've been at Brown since December, and before that I was at Brigham and Women's in Boston. The first thing I can say is this is the first time I've been involved in a discussion about climate change and health in the healthcare system. And so neither of those hospitals had any active discussion about climate change. I do think in the emergency departments in both areas we were seeing initial some changes due to climate related health. The two that I would call out are Lyme disease, which is endemic in the Northeast, particularly in Rhode Island. But what we've seen with warmer winters is that the life cycle of the vectors, ticks are often out earlier. There's larger populations because of mouse populations, and so we're seeing people come in with Lyme disease in areas further north than they typically would be, and also at times of year when you wouldn't typically think of it. And I think that's sort of one general theme is about emerging diseases. And then the second is heat-related issues. Last summer had a long heat spell in the Northeast, and in Rhode Island, I forget the number of days, but there were several weeks where it was above 90, which is quite unusual for New England. And where that I think affected emergency medicine was in older adults, like was seen in France, 5 or 7 years ago. Rhode Island is the second oldest state in the country, and we know about young people outside during heat, but these prolonged heat events where people are stuck inside, may not have air conditioning, may not have people to look after them. There were definitely more cases of older adults coming in with heat-related issues.
Good morning. So I have spent 30 years as a practicing emergency medicine physician. I was chair at Emory for 12 years and made a big switch and moved back to New York, where I grew up, and I started my new position as Chief Operating Officer at NYP Weill Cornell in August of 2018. And I must say, it's been a remarkable journey from the perspective of an integrated healthcare system and the impact that major events have had on the city of New York and the region as a whole. So if you think about it, New York was really literally rising from the ashes of 9/11 with that, indomitable New York City spirit, and rebuilding and rebuilding. And then in 2012 was hit with Hurricane Sandy, which was absolutely devastating for the island of Manhattan. All told, almost 300 people actually lost their lives from the impact of Sandy. the impact to the region was almost $20 billion. The subway was shut down, and 8 hospitals were closed, and 15 nursing homes closed during the time that Sandy was having its greatest effect. Part of the New York Presbyterian system is a hospital in the lower part of Manhattan, and that hospital had to be closed and evacuated. Where I am now as Chief Operating Officer became the major receiving hospital as the waters were literally rising into the lower part of Manhattan. And so I would say to the question around lessons learned, there were many, and perhaps we will get to that. But New York State and New York City, I think as a whole, have responded pretty well to issues related to disaster, and have really, I think, taken an all-hazards approach. Having come from the state of Georgia, where it's fractious and sort of the responsibility is a bit dissipated, like water on filter paper. One thing I will say about New York is they have actually banded together and really done some good things. But if I talk to the people in the hospital, and particularly at Lower Manhattan, who lived through 9/11 and then went through Sandy, having spent time from the EVS workers to the frontline nurses to the physicians, they really have almost, some of them, post-traumatic stress disorder from the incredible disruption and loss of life and everything that they went through. So this is not for us, I think, a question in emergency medicine and in disaster preparedness and in healthcare of if, but really a question of when. And so how can we, as emergency physicians, grab the mantle and really run with it in terms of helping the healthcare system take the lead?
Thank you.
Thank you so much for sharing your experiences. I think there is nothing more powerful than a narrative, and I think that's an important thing that we can all take away, that we have a very powerful way to put the human face on climate change in a way that those others, sectors that are very critical, that we interact with in a multidisciplinary fashion, just don't have the ability to do. So I'd love to, and you highlighted some of these issues, but would love to kind of nail down and say, in your opinion, like what is the one most pressing issue facing emergency medicine as we attempt to face climate change?
I'll answer briefly and then look for my panelists to expand on this. But we've really got to take an all-hazards approach. If you think about it, fire, water, heat, infectious diseases, there are unified approaches in disaster management in terms of responsiveness for us to get through this. But what I do think we can do is really grab hold on how we can better prepare rather than respond. And I'll come back at the end and think about some ideas that we're thinking about in my institution.
And I'll add to that, similarly, I would specifically say hospital readiness. I think, what Kate pointed out was the incredible impact in New York of Superstorm Sandy, and a lot of that was due to low-lying generators, and so Bellevue, a 30-story building, had to be evacuated because the generators went out because water went into the ground floor. It's interesting because Rhode Island is a coastal state with lots of low-lying real estate, and so the state has a huge issue in the future with climate change. The 4 hospitals that we staff happen to all be quite high enough away that we're okay, but there are other hospitals in the state, and so there will be issues when there is a big storm about other hospitals being affected, so we're going to have to be ready for that.
I think for emergency medicine specifically, I think we're in this phase where we need to mount education of our own group. I liken this a little bit to perhaps what wellness was a few years ago, where people generally kind of knew about it and accepted it, but only recently I see a groundswell of interest in making that better and actually doing research and publicizing that, and there are a lot more people interested. And I think right now, despite the fact it's one of the last sessions of the meeting, I think we're saying we're still a relatively small population who's interested in this issue. So we have to educate, I think, ourselves, specifically our individual faculty in sessions like this, but sessions otherwise, as a critical mass initially before even we start necessarily educating the public.
We've set up at New York Presbyterian a number of systems so that we've got much better redundancy. Entire satellite communication systems. We have worked very closely with our vendors in supply chain so that we have 96 hours of supplies on hand, and created redundancy such that if you cannot get in through bridges and tunnels on the west side of Manhattan, we've got a supplier who can come in on the east side. If you can't get in east or west, we've got helicopter opportunity to bring supplies to the hospital. These are the kinds of things that, honestly, nobody thought about 10 years ago. Nobody thought about. We've also done a lot with communication with respect to the InfoNet for all the employees and ExfoNet. We've got an opportunity to house 600 staff members in my hospital on the drop of a dime with cots and linen and the like. And in response to things like storm surge and rising waters, the building that we opened a year ago is an ambulatory surgery center for 9 floors, and now we're building a women and newborns hospital on top of that. That's risky. You're taking an incredibly vulnerable population and putting them in a new building 18 stories up. What they did, as Jay said, because of storm surge, we put all the generators on the 9th floor of this facility, and it's been built to withstand winds of 150 miles an hour, and also, you know, with terrorism, big bomb detonation on the ground floor. These things are expensive. I mean, that building is probably $1.5 billion or more to construct, and that's difficult for healthcare systems. So this is really a concerted effort. I do think there's opportunity in philanthropy. I happen to now be in a place where philanthropic opportunity is greater than I've ever seen. But that said, I think that this is a tug on the heartstrings and think about future generations with respect to climate change. And emergency medicine, again, can be healthcare system leaders with respect to some of those opportunities.
So you guys have all been very articulate this morning about these issues, and there are a couple of themes that I want to pull out and then ask you about even to elaborate on further. The first one is that you've experienced issues, you and your systems have experienced exposures that were probably exacerbated by climate change, going away from the attribution question. But the all hazards framework is key and very resonant for us. And so one thing that I'd like to hear more about is how you integrate and update your risk assessment in the all hazards approach. And you mentioned that your hospitals, Jay, are okay, but the others in the system probably aren't. And I'm wondering how that assessment, how that judgment was determined, whether it was just sort of, yeah, this is the way it was eyeballed, or it was actually formally done. How collaboration among these different systems is facilitated and maintained. And then also, Kate, you talked about how all of the preparedness is really expensive. I'm also curious about the recovery. The recovery, you mentioned the smoke being around for months. You've got now thousands of people homeless from Paradise. Where are they going? We know that this is a complex issue that has long tails in terms of the impacts, and that impacts emergency medicine as well. So a lot of different things there. Feel free to take it in whatever direction you'd like. But
So I'll just specifically answer the question. I was oversimplifying about our hospitals. I was specifically referring to storm surge, that as a low-lying state, we have a huge number of communities that are very at risk of storm surge. It turns out that the 4 hospitals we have their physical structure is not at risk. There would clearly be issues in terms of infrastructure, energy, and other things. There's been discussion about that after Superstorm Sandy, that one difference about my health system compared to the two other health systems is we're a financially strapped healthcare system. And so we have a tough time just dealing with regular capital issues. And so there is not a big discussion about what we're going to do in terms of a lot of redundancy, because we're just trying to keep the lights on.
Yeah.
And I think that's a big issue in large parts of the country.
I wanted to mention additional impact on the fires specifically, as we also in emergency medicine have, deploy like USAR and FEMA and those sorts of organizations. I had several faculty and our residents, actually, our residency director sitting right there, cobbled together an elective like overnight, essentially, so that they could go up and assist in that process, which was a great opportunity for them to learn and also be exposed to that. But even the PTSD of those providers, one of the urban search and rescue people who was up there, it became basically body recovery, not rescue at all, and that was really had profound impact.
One of the things that I wanted to comment on, I think is unique to the state of New York, but I'm not sure, and hopefully somebody can, who's got more expertise in disaster management than I can correct me. But in the aftermath of Sandy, one of the things that was implemented with respect to displacement by the New York State Department of Health is something called e-fines, which is basically a bracelet, almost like an RFID, evacuation of facilities in disaster systems. So patients in nursing homes, patients in inpatient settings automatically get this bracelet placed on them, and with just a barcode reader, no matter where they're sent throughout the system, it's got their basic information, sort of name, rank, serial number, medication allergies, very, very basic things, but those patients can be tracked. And if the system goes down, there's redundancy then with a paper system. We have also, all of us have experienced what I would call infections of displacement. So if you think about it, in the aftermath of Katrina, there were some really interesting MMWR articles that came out around a spike in Vibrio infections with brackish water. All right, both GI and also skin infections, norovirus infections when you put people together like cruise ship, when people are displaced and they wind up living in in communal setting, and then also MRSA, same thing when they're sharing towels, sharing razors. So there's that kind of thing as well on top of all the emotional disruption that goes on. So the more we have learned about these things, the more we can prepare and have that sense of readiness.
Thank you.
Well, we have other questions, but we also want to make sure that we address burning questions and thoughts from you. So does anyone have questions that they would like to ask our panel? Yeah. I'm going to pass around mics. We're told to always speak in a mic. Thank you.
Thank you guys so much for the talk. It was amazing. Your experiences are really interesting. I think it's cool how there's a diversity of geography. I had a question. I know we talked about how we're trusted messengers in our specialty, and particularly our profession. But we touched on also that not everyone is really educated in these issues. So for, I guess, quote unquote, the layman doctor who doesn't really know about climate change, what are some examples of a conversation that they can have with a patient at the bedside that would kind of help us spread this message?
I think it's difficult, right? Because in some ways, we have lots of conversations with our patients regarding several different things. The unfortunate part of this is that the conversation is so politically charged. So we have the challenge of the science and essentially explaining science and medicine to a patient, but then that other complicating thing. But I think in general, most patients understand things from a visual perspective, and ultimately, I think the more we can get, emergency medicine has the benefit of having sort of that bang factor, that wow factor, that high interest factor, that educating the lay public regarding some of the things that happen. I mean, very much the same way I can't watch when the SPCA commercial comes on, whatever, because it's so, I mean, well, it's true, right? It's very impactful. And I don't have an answer on how to describe it or how to educate the individual patient, but I think we can educate patients at large through things that are visual.
And I don't really see a role for talking about climate change in individual patient interactions in the emergency department. Maybe there will be at some point, but I see our role as trusted voices of reason sometimes to be able to speak up in our health systems, in our communities, in other organizations we're involved in, to talk about the stories we're talking about, to try to bring the impact of climate change to people. So that would be my thought.
I think one thing that we might think about, and again, whether it's emergency medicine doing this or primary care providers or what have you, is just to remind people or teach people to be ready, to have that go bag so that they can be prepared. I think that is, from the very basics of public health. I remember Jeremy and I were colleagues at Emory for many years before he moved to the West Coast, and we were envisioning all kinds of things in the setting of bad flu, like fast flu drive-through, or using the U.S. Postal Service to drop things into mailboxes. I recognize climate change has its own political charge, but if you're talking about trying to teach a population to have a sense of readiness, I think we can take the politics out and just try to prepare the general population for that sense of readiness. Having medications, having a go bag, a plan for your pet, that kind of thing. We have an app, by the way, in our healthcare system. Many of you probably do. It's NYP Be Ready, and so I got it on my phone. You can pull that up, and it's got all the things that you need to be thinking about and what to do in the setting of several different natural disasters. And that's the kind of thing that I think we can think about in terms of public funding to get the message out to the general population.
So I'm hearing a lot about resilience, which is certainly important, but I think that's only one piece of the equation. I'm curious what you in your departments or in your institutions are striving or advocating for with respect to reducing healthcare's own impact in causing or contributing to these ill effects.
So thanks for bringing that on, bringing that up, because I had a bunch of notes about that were something that I wanted to comment on. So Jonathan Slutzman from MGH, and I think people who have an interest in this should look at the work that Jonathan presented on life cycle energy intensity in healthcare. I honestly think this is the biggest area we have an impact. Healthcare is 18% of the GDP. It's incredibly energy intensive, and there are two ways that we can have an impact. The first is around cost. Why do we use a disposable suture kit from Pakistan or China? That was not what we used when I started, and I'm not that old. And the reason is because healthcare costs so much. And we do that because it costs more to hire somebody to autoclave that equipment than it does to have it made abroad with cheap labor with very energy intensive processes. And so anything we can do to reduce the cost of healthcare actually will help on the climate change prevention front. And then the second stream of that is the energy intensity of our practice. And so things that we can do to first study this, I think it's something it has not been really well identified. There's a lot of work in healthcare architecture about LEED buildings, but most of the stuff we do in terms of equipment, procedures and other things, it's not clear how much energy intensity there is and what we can do about that. And so things that we can do to reduce waste, in particular, like a simple thing that we're starting to work on is just what needs to go in the red biohazard bag, which is going to go and get incinerated, versus what can just go to the landfill. That's a direct energy impact, and when you multiply that across a hospital, across all of the hospitals in the United States, that's a huge impact.
So there's inherent conflict for some of the things. We're moving towards more and more disposable medical equipment rather than durable medical equipment because of the expense of sterilization and otherwise. So on one hand, we're mitigating perhaps infection risks and those sort of things, but actually making the problem worse in another way. I think recycling some of the equipment as an idea, and I'm talking about like significantly large equipment. So we're closing, well, not closing, but opening a new hospital and shutting down parts of the old one. But there's a concerted effort to actually move some of those larger machines, CT scanners and otherwise, but we have new ones in the new hospital, but they're still well within their lifespan, to other hospitals perhaps who don't have as much capital to buy some of that equipment. So at least we're not creating a bigger problem by having to throw all that away.
I'll take a slightly different tack, which is to say I think emergency medicine physicians, scientists are really well positioned to tackle it from the perspective of artificial intelligence, machine learning, predictive analytics, so that we can, again, it's preparedness, but it is also the potential of diminishing the fact that a person might even need to go see the physician in the first place. Therefore, you're not getting in your car or you're not getting on a bus. There's opportunity for wearables. There's opportunity for telehealth visits. I think that there are, and we can really be the leaders in this. There are not too many specialties that have really jumped on to the telemedicine bandwagon. And I think that emergency medicine is exceptionally well positioned. We are very comfortable with a small amount of information and just a face-to-face look at somebody to see how they're doing. So the opportunity to reach into people's homes or to talk to other physicians through video or to deal with sort of an air traffic control, almost an EICU predictive analytics opportunity, whether it's looking at storms or looking at vital signs or what have you, those are the kinds of things that we can do that actually are energy diminishing because of the impact around foregoing a face-to-face visit or preventing something from even happening in the first place.
Let's do some summaries. We have 4 minutes. Okay. We have 4 minutes left, and I want to make sure that we're respectful of time. And again, thank you so much for spending time here. I'm just going to have a few closing statements, and Jeremy can do the same. And that's that emergency medicine is truly on the forefront. I think we've heard from some of our esteemed leaders in the field, and this is the first discussion of this type happening on this platform within our specialty of emergency medicine. And we have a profound opportunity as citizens, as physicians, and as, I would argue again, a specialty that is truly on the forefront and has a pulse on our communities, and we're seeing these impacts that we need to, as a community, step forward in unity and really embrace this topic and help lead healthcare overall, but also our world into the future that we can imagine. And so I hope this is just the beginning of many more discussions. Conversations can obviously continue after this as well. And I will let Jeremy have a few statements, and then I'm going to try to get all of you to come to our interest group meeting, which is next.
Okay. Well, a couple of things have stuck out for me from this really engaging panel discussion. And the first is that stories and experiences really matter. They matter not only for us individually, but they matter for us collectively in creating narratives about how we respond, how we support each other, what worked well, what didn't, what we can do better in the future. And I think we need to keep telling these stories and be on the lookout and think about ways that we can mention climate change as part of that without being heavy-handed, because really it is, each event is different, and climate change is a part of some of them, and that's important to acknowledge, but it's not the end-all be-all. The end-all be-all is taking care of our patients and our colleagues, and those stories matter. The second piece is that we need to play to our strengths, and we have a lot of strengths as emergency physicians and as a collective group, and the panel has highlighted that well. Each of you has demonstrated that in your careers. You've got a lot of strength and have really navigated lots of complex waters very effectively. And playing to our strengths in this issue will really help see us through, because we actually are in a very good position to take this on, which is great because we have no choice. Come inside us. So I want to lend my sincere thanks to you for coming and lending your voice and your perspective. It's really been great to hear. And thanks to all of you for coming and demonstrating your interest, and I hope that you've learned something and will take something away. Thanks.
Thank you.
Thank you.